Pancreatic Cancer Day, part of Pancreatic Cancer Awareness Month. Today we are joined live by Dr. Rebecca Keim, a general surgeon at St. Peter's Hospital, specializing in hepatobiliary and pancreatic surgery. Dr. Keim is here to talk about some of the latest treatments for the disease. Hi, Dr. Keim. How are you?
Hi, good, thank you.
Let's start out by talking about some of the risk factors and symptoms for pancreatic cancer.
So the primary risk factor for pancreatic cancer is actually a history of smoking. Most people aren't aware that pancreatic cancer is one of the strongest smoking-related cancers. At least 20 to 30% of our pancreatic cancer patients are current or former smokers. Other risk factors include age and obesity, a history of diabetes, and a history of chronic pancreatitis. There's also a subset of pancreatic cancer that's familial, so either associated with several genetic cancer syndromes or just associated with two first-degree relatives with pancreatic cancer. Some of the symptoms that we often see are fairly subtle, which is why oftentimes we do not catch pancreatic cancer until it's fairly advanced in stage. It may be something as simple as some unintentional weight loss, abdominal discomfort, particularly upper abdominal discomfort, radiating to the back. Occasionally, if the tumor is located in the head of the pancreas, they can develop jaundice. Also, new onset diabetes in an adult is often a warning sign for early pancreatic cancer. Also, just early satiety and difficulty eating.
Once someone has been diagnosed with pancreatic cancer and referred for surgery, what can they expect during that first surgical consult?
So honestly, most patients with pancreatic cancer often do not even get to see a surgeon. That's because they're diagnosed at such a late stage that surgery would not be an option for treatment for them. The few that we do get to see, really the most important thing is to develop good rapport with them and to educate them and their families about their diagnosis. Obviously, we carefully review their pathology and their imaging studies as well as their biopsies and decide whether or not the tumor is something that can be treated up front with surgery, which is considered a resectable tumor, something that perhaps needs chemo or radiation prior, which would be considered borderline resectable, or what we call a locally advanced tumor, which means at least at the current state is not something that can be removed safely. Also, occasionally we do see patients that are metastatic at diagnosis. Once we sort of determined their type of tumor and whether they could have surgery, we then basically educate them on treatment options. Pancreatic cancer needs to be treated not just with surgery alone, but with multidisciplinary management. So the vast majority of patients require chemotherapy, sometimes radiation ahead of surgery, and all require adjuvant chemo afterwards. Because of this, we work closely with our medical oncology and our radiation oncology colleagues to help us co-manage these patients. Also, a lot of the visit is spent allaying fears and answering questions. We spend a lot of time doing that and providing them with important resources for that.
Any typical questions or concerns that you hear from patients?
I guess, first of all, they want to make sure that we have the right diagnosis. I think a lot of the public is aware of that it's a very serious cancer. They also want to know a little bit about what options are out there for them and what's their chance of being a long-term survivor from this. Honestly, whenever pancreatic cancer, we talk about prognosis, and it's pretty rare to be a long-term survivor. So we have to be very upfront with them about what our hope is for them. And obviously, the hope for all pancreatic cancer patients is long-term survival and a good quality of life. And so from a surgeon standpoint, we want to provide excellent surgical care to get them back to living their life with a good quality of life.
And what about latest treatment recommendations for pancreatic cancer? You mentioned chemotherapy and combined with surgery.
Right. So I guess, obviously we want good imaging with a good early diagnosis of the disease. We want multidisciplinary input into their treatment. And the vast majority of patients do get chemotherapy prior to surgery. This both gives them a sense of their tumor biology, meaning we can see how the tumor is going to behave in response to chemotherapy. Sometimes tumors respond to one regimen of chemo and not another. So if they're not responding with preoperative chemo, we can switch out the chemo to help them have a better effect. And then obviously we want to get them through surgery and recover after that. In terms of experimental treatments, there are obviously lots of clinical trials nationwide, mainly for metastatic or unresectable patients. There's vaccine trials, there's immunotherapy trials that are having some brighter lights in treatment. And I think the biggest thing is diagnosing patients early and getting them treated as soon as possible.
Is there anybody who maybe has some risk factors for the disease? Is there anything that they can do to prevent the disease?
That's a good question. There's no really proven treatment or prevention treatment for pancreatic cancer. Obviously, people with a very strong family history of pancreas cancer should be enrolled in a surveillance program, which is usually a combination of MRI as well as endoscopic ultrasound. So anyone that has at least 2 first-degree relatives of pancreas cancer should be seen by a qualified gastroenterologist and enrolled in surveillance. Then if in surveillance they see any high-risk lesions, like a pancreatic cyst, for example, they may want to undergo surgery to resect that lesion, as the risk of cancer is higher than the average population. Otherwise, just from a population standpoint, smoking cessation, quitting smoking can help you reduce your risk. We do see a subset of patients that have some premalignant cysts. One type are mucinous cyst called an IPMN. Actually, resecting and removing those cysts is really the only way I as a surgeon can prevent pancreas cancer, and we do see a lot of patients with that disease subtype.
Great. Anything else you'd like to add?
Other than, I enjoy taking care of pancreas cancer patients. I think in some ways, even though their diagnosis can be quite troubling, they're some of the most hopeful patients I see. They come to see me and I talk to them about undergoing a pretty major operation that has some risks with it. And I also talk to them about having prolonged chemo both before and after. And they're very brave in their approach, and that they sign up for this whole package, which could be, pretty disruptive to their lives, with the hope that they're going to become a long-term survivor. And obviously, that's always a hope that I have for them.
Great. Thank you so much, Dr.
Thank you.
Keim.
Thank you.